Hi everybody, welcome back to another episode of our punch videos, our HEMSI punch that we're serving approximately weekly. Little bit spiked sometimes, otherwise a little more benign. This one is a little spiked. This topic I wanted to talk about because I actually had a case that made me think that this was worthy. The last shift I worked, I had a paramedic call me when I was in APOD, saying that he was bringing me, this was an outside agency, not HEMSI. He was bringing me a patient 45 minutes away with atrial fib with a rapid rate. This lady was having a lot of chest pain, and he had cardioverted her, he said, with 100 joules. And she was still in atrial fib with a rapid rate. What would I advise? And I paused and gave him advice to start diltiazem, and we talked about this. When he got the lady to me, she was still in A-fib, but he asked if I would have done things differently, and we sat down and talked about it, and yes, I would have done things differently, so we would talk about this. What is atrial fibrillation? Atrial fibrillation is, by definition, a chaotic rhythm of the atrium. The atrium is quivering. It's just kind of jiggling there and not contributing significantly to the cardiac output. So you see the ventricular beats, and if you'll notice on this comparison, the top line represents A-fib. You don't see clear P waves preceding the QRS, and it's just kind of chaotic, and it's irregularly irregular. There's not a pattern to your QRS rhythm. The P is normally your atrial beat. There isn't one. Your QRS is your ventricular beat. So it's irregularly irregular and narrow. In sinus rhythm, you see a P wave before your QRS. So that's the big difference. Then if you look at a 12 lead on this, look at your rhythm strip, because if you just look at the 12 lead, it can look fairly regular. But look at your rhythm strip and you'll see that it's irregularly irregular and narrow. And in this case, fast. The rate's about 150. So your questions are, okay, what is the rhythm? You find out it's A-fib. Okay, well, what is the patient's history? What are their symptoms? Find out, are they having chest pain? Are they having lightheadedness or just palpitations, shortness of breath? Secondly, do they have a history of atrial fibrillation? If they do, then they may know what medications they're on. They may know if they have it paroxysmal atrial fib, where it's sometimes they're in it, sometimes they're not, or if they're always in AFib, which some people are. Once you do know that history, ask them about medications. They may be on a blood thinner, which most people that are in and out of AFib are put on. The reason for that is that if you're in AFib, you've got this quivering atrium that blood can be a little stagnant in, and so in the atrium, especially in the little appendage that sticks off the atrium, you can get blood clots. If those patients go into sinus rhythm again, then that atrium starts compressing, and when that atrium squeezes, it can shoot out emboli that can go to places like your brain that matter, and you could have a stroke because of this. So it's important to know whether they are on blood thinners, because if they are and we ultimately need to cardiovert them either medically or with electricity, it'll be a safer process to do this. So are they on other medicines for their rhythm? And there are several that are used to treat this: DIG, MEO, a lot of different medicines, beta blockers, and diltiazem. So their EKG shows it. Okay, irregularly irregular, narrow. Is it fast, slow, or normal? If it's slow, you treat it as you would treat other bradycardias if they're symptomatic with a bradycardia. If it's normal, hey, no problem. That they're in AFib, it's not a problem for them right now. You don't need to treat that rhythm. If it's fast and they are very symptomatic, their blood pressure's low, they're in shock, and shock can be a lot of things. Usually, if their mental status is low, their blood pressure is very low from this. So you look for signs of shock. If they have a pressure of around 90, I wouldn't be too excited. If their pressure is 70 and they're altered and they're clearly in distress from this with shock, then you want to do something about it. So what do you do for AFib with a rapid rate? The main thing you want to do is get them to the hospital safely. You want to bring them to us and bring it safely. Generally, this is not a rhythm that you're going to get super excited. It's not V-fib. You're not going to rush in with paddles at, within 30 seconds. It's a fairly stable rhythm. So you want to assess it, take a deep breath, and see where to go from here. If they are in shock, then that's when you want to be thinking cardioversion. And we're not going to talk specifically about the how-tos with cardioversion here, or more to come on that later. But you want to do synchronized cardioversion on that small segment of this population. If the rhythm is just fast, but they are symptomatic from it, they're having severe chest pain, their blood pressure might be a little bit low, but they're just needing treatment for it. And especially if your transport time is long, like my guys, they were bringing me somebody 40 minutes away. Then it's time to think about starting your diltiazem. And Jean's going to do a follow-up video right after this one that'll explain to you a little more about how to do this and when and the mechanics of giving diltiazem. But that's when you think about starting that. Your goal is not to convert them from the A-fib to sinus rhythm because of those dangers we talked about. Your goal is to get the rhythm slowed down so that they're handling it better. And then, a lot of these people will convert spontaneously later. If they are on medications, it's important to let us know that. So you consider the diltiazem, you deliver them to the hospital. If you have a question of whether this is really A-fib, sometimes you can have A-fib with a wider complex, and occasionally that can be something called WPW, Wolff-Parkinson-White syndrome. If you see something that just doesn't look right, doesn't smell right to you, by all means, call medical control. Send us a picture, send us the EKG, because that is something where you would not want to give diltiazem or amio or anything, because those medicines may block that pre-excitation pathway. They may block the AV node and cause them to go into A-fib. Cause them to go into V-fib. Bad, dangerous, deadly rhythm. So you want to, if you have a doubt, send the EKG and we'll show you this is what WPW looks like. It's a little scary, and on their baseline EKG they have a very short PR with something called a delta wave. But this is what it looks like when they're in a rapid rhythm with it, and it's a very dangerous rhythm that you want to manage very specifically. You don't see it very often, thank goodness. All right, well, thank you for your attention, and we'll close this out and proceed with Jean showing you the specifics of diltiazem administration. Thank you.